want to delay anybody too long and delay us from our content tonight. So thank all of you for taking the time to tune in for tonight's Next Generation Editors Journal Club, which is our second installment of our ASJ Journal Club series for 2022. My name's Ryan Austin, and I am the lead of the Next Generation Editors, and I'm a plastic surgeon in Toronto, Ontario, Canada. And I'd also like to introduce Dr. Maryam Zamani, who is our fellow ASJ Next Generation Editor. She's also going to be our discussion curator tonight. So make sure you keep your chat box open, and if you have any questions or comments that you'd like to post as we hear our presentations tonight, feel free to type them away, and we'll try and get to as many as we can. And also make sure that you respond to any of the poll questions that come up throughout the evening. Tonight, we're going to be reviewing a topic or an article from the March 2022 issue of ASJ entitled Computed Tomography Analysis of Nasal Anatomy in Dorsal Preservation Rhinoplasty, and its accompanying commentary article. We're fortunate tonight to be joined by Dr. Jeffrey Larson, who is one of our Next Generation Editors from Madison, Wisconsin, who's going to be providing an overview of this month's article. And we're also excited to have two co-discussants and two experts with us tonight for the evening. First up, we have Dr. Priyesh Patel from Nashville, Tennessee. Dr. Patel completed his medical school training at the University of Wisconsin before heading to Nashville to complete his residency in otolaryngology head neck surgery at Vanderbilt University Medical Center. After completing his fellowship in facial plastic and reconstructive surgery at Stanford University, Dr. Patel then returned to Vanderbilt, where he is currently an assistant professor in the Department of Otolaryngology head neck surgery. Dr. Patel has published extensively about dorsal preservation rhinoplasty, and we're really fortunate to have him here with us tonight to share his expertise and experience. Our second co-discussant for this evening is Dr. Jason Roostaeian from Los Angeles, California. Dr. Roostaeian received his medical degree from the David Geffen School of Medicine at UCLA before he completed a combined residency in general and plastic surgery at UCLA. Dr. Roostaeian then went on to complete a fellowships in aesthetic surgery at UT Southwestern and microsurgery at UCLA before starting his practice in Los Angeles. An associate clinical professor at UCLA, Dr. Roostaeian has presented and lectured around the world on rhinoplasty and is just back from the Dallas rhinoplasty meeting, so no doubt that he's going to have some excellent insights and advice for all of us tuning in tonight. I don't want to keep us any further, and we have to get to this content, which is going to be fantastic for discussion tonight. So with that, I will hand the reins over to Dr. Larson for his presentation.
All right, thank you, Ryan. It is a pleasure to be able to provide a quick summary of the Journal Club article. And I believe that, let's see. All right, I believe we should be good to go here. So I have no disclosures. This is a study from Dr. Aravsi and his colleagues from the ENT department in Konya, Turkey, that analyzes the relationship between CT imaging and pertinent anatomy and dorsal preservation rhinoplasty. In recent years, dorsal preservation rhinoplasty has become more prevalent. In this technique, the dorsal hump is preserved and reorganized using existing anatomy, unlike the resection and reconstruction with cartilage grafts of conventional techniques. In this technique, there are several critical anatomic points to ensure not only an acceptable cosmetic result, but also a safe approach given the proximity to the skull base. These points include the level of the septal bony cartilaginous junction, or the K area, and then the distance between the K area and the radix incision, as well as the nasal bone thickness in this area of the radix. The goal of this study was to use CT imaging to evaluate the nasal bone thickness, the level of the K area, and the distances of the frontal sinus and skull base from the intercanthal line in a population of rhinoplasty patients. This is a retrospective study of consecutive paranasal CT scans in over 200 patients. There were 4 measurements that were taken, including the nasal bone thickness at the level of the medial canthus, and then the relationship of the transverse osteotomy to the K area, to the frontal sinus, and to the cribriform plate. This is figure 1 from the paper. I have taken the liberty of kind of blowing up the anatomic area of focus that illustrates the area of these anatomic measurements that were taken. The results demonstrated that there was no significant difference in these measurements between age groups, but there were differences between gender, with females having thinner nasal bones and a more cephalic position of the K area. This difference has important implications for the approach during surgery as it relates to removing a septal strip of cartilage versus the need for resecting a portion of the ethmoid bone. I'm sure this will be part of the discussion that we'll be looking forward to in just a few minutes. Here's another pre-op and post-op image of a patient who underwent high strip preservation rhinoplasty surgery. This image on the left demonstrates the radix incision and the relationship to the frontal sinus, which may extend down to the nasal bone in some patients, and it also demonstrates the distance between the transverse osteotomy and the cribriform plate. So despite some minor limitations of it being a retrospective study and the limitations of CT imaging, I'd like to compliment Dr. Aravsi and his colleagues for a very elegant study. Looking forward to a good discussion here in the next several minutes.
That's great. Thank you so much for that excellent review, Dr. Larson. With that, I'd like to hand things over to Dr. Patel for his thoughts and some comments on the article and on dorsal preservation rhinoplasty.
Thanks, Dr. Austin, and the rest of the team here for having me today. First, I totally agree. I think the authors are to be commended. I think this is an important topic that addresses a couple different issues. The first, which is simply just nasal anatomy. And with the rise in the popularity of dorsal preservation, I think our critique and evaluation of nasal anatomy has actually expanded. The second of which is the safety and the avoidance of complications in rhinoplasty, and ultimately the utility of a CT scan. And while the article is written actually in the context of preservation rhinoplasty, I think the anatomy and the concepts are actually pertinent to structural rhinoplasty as well. So that being said, and knowing that the audience here will likely have a varying understanding and implementation of preservation rhinoplasty in their practices, I do think that a valuable element to focus on here is some of the anatomic findings from this work. So first, it's previously actually been well described really at this point that the cartilaginous septum makes up a significant portion of dorsal humps with an extension of that septal cartilage under the nasal bones. And based on both cadaveric and radiographic studies, this extension in literature actually has ranged from 7 to 11 millimeters or so. And this concept is a fundamental element of preservation rhinoplasty because it implies that the excision of septal cartilage, when combined with this relatively flexible junction of the dorsal perichondrium with the periosteum, plus osteotomies at the radix and the nasal sidewall, will allow for not only a descent of a dorsal hump, but also a flexion at the apex of the dorsal hump, thereby reducing it. There are so many variations now on preservation techniques, both in the management of the bone, the midvol, and the management of the septum. But the focus of this article are two important elements of this technique, the first of which is the septal cuts, and the second of which is that radix osteotomy. And in part, the focus on these two is valid because there is this theoretical potential for skull-based complications with both of these. So let's first talk about the septal cut. With regards to that, the majority of that in dorsal preservation is going to be a cartilaginous cut or resection. And in fact, some authors and other preservation experts have actually suggested that the amount of bone that really needs to be resected underneath your dorsal hump is extremely minimal. Too much of bone resection actually, and those of us who have actually tried introducing this into our practice and tried it have learned that too much resection, and one of the biggest complications or easy things to make a mistake on is this drop in the radix height. And so really minimizing the amount of bone resected in this area is, I think, important. Another consideration is that sometimes rather than resection of bone, a longitudinal cut with subsequent side-by-side movement of that dorsal bone with that septal bone is actually more likely to prevent this radix drop and just be enough for the amount of dorsal lowering that you want. With that being said, I don't think that the bony septal cut is particularly dangerous when considering the distances that are reported here from the frontal sinus and the cribriform. Obviously, one shouldn't be torquing on this area or drive an osteotome aimed posteriorly, and perhaps using sharp instruments or narrow-bladed double-action scissors or even a piezo, which has become obviously extremely popular now in preservation rhinoplasty, would be helpful and prevent these complications. And regardless of whether or not you have a preoperative CT scan or not, I'm not convinced that you're not going to take these precautions anyways. Also, for those of you who have worked on complex frontal sinus cases, such as the Lothrop procedure, or have ever dealt with an NOE fracture, you know that this area of the septum is not uncommonly manipulated, and it's done rather safely. So second is regards to the radix osteotomy. And the first question here is where do you make that radix osteotomy? The authors here suggest that the landmark to use is the medial canthus, but others, myself included, don't necessarily always use that landmark. And many of us make this at the start of your dorsal hump. The reality of it is that this osteotomy site is just not going to consistently be made at the exact same external landmark in every patient. So it's not surprising that if you look and read through the literature, there's quite a bit of discordance with regards to the amount of septal cartilage that extends beyond the site of your osteotomy. So for example, Dr. Ferriera, who's a well-known now preservation rhinoplasty surgeon, reports that 97% of patients have cartilage that extends past the start of their dorsal hump. So for me, if I was using his landmarks, then I would say, gosh, anytime you make that radix osteotomy, you're just about never going to get into the perpendicular plate of the ethmoid. Another author has suggested that about 37% of patients don't have cartilage under the start of that hump. That's a very significant difference between that 97% that was reported by Ferriera. And many of you may know Dr. Saban, who is a contemporary father really at this point of preservation rhinoplasty, and somewhere he has reported that there's a mean of about 7 millimeters from what they have delineated on imaging to be this transverse radix osteotomy plane and the end of septal cartilage. So that's a pretty significant distance away from your radix osteotomy. So then the question becomes, well, how do we safely determine, or how do we come up with a determination of the safety of this procedure? The first of which is that many times a drop in the radix is not wanted, as I've already mentioned. Rather, it's this hinge effect at that radix or the start of that dorsal hump. And therefore, the osteotomy is actually not being driven straight down perpendicular or even angulated upwards, but rather it's an obliquely made osteotomy that sort of skives towards the more caudal aspects of the nose. Also, if the septal cuts or the disarticulation of the septal bone from the overlying nasal bone is made prior to this, there's an idea that maybe this radix osteotomy is actually a safer move. Again, would these maneuvers change whether or not you had a CT scan or not? I don't really think so. So while I think the anatomical evaluation of the keystone and nasal architecture is a valuable addition, I'm not sure that the conclusion entirely applies to every aesthetic rhinoplasty case. Now, that being said, you'll find that the concept of preoperative CT scans in aesthetic rhinoplasty has actually garnered quite a bit of support. And there's a group that actually found that patient satisfaction, when patients were given a preoperative CT scan, the surgeon had the ability to evaluate it and then make some surgical plan, patient satisfaction was actually higher. But if you read carefully in this article, it fundamentally came down to the fact that, hey, they just picked up on a bunch of intranasal pathology that they then corrected. For example, concha, that they corrected at the same time of their aesthetic rhinoplasty, and now a patient is happier. And so they report, gosh, look, if you get a preoperative CT scan, patient's going to be happier on the back end, which, I think is not entirely true in the setting of solely aesthetic rhinoplasty. And Dr. Ferriera, who I alluded to earlier, in his work, he actually commented on the fact that, hey, if you're ordering a CT scan based on some suspicion for some nasal pathology, then yeah, you should use it to take a look at the nasal architectural and the bones, et cetera. But to order it solely for the aesthetic planning purposes was not recommended by him and his group. And I tend to lean towards that mentality. Now, contrast that to a fantastic rhinoplasty surgeon, Enrico Rabati, who he wrote a fantastic article on on the use of cone beam CTs and how this has really guided his preoperative aesthetic decision making and how it's made his life easier in the operating room. And I encourage you guys to read that, because it does, open your eyes with regards to maybe the validity of the CT scan. But for the most part, if you don't have one, will you be unsafe based on the anatomy that's been described in papers such as this one? I don't think so. Will you have a better aesthetic result? I'm not so sure. And perhaps that's something that each of us in our own practices will just have to see. And perhaps that's even a research question idea. How much does a CT scan really change your operative plan and the aesthetic outcomes or complications that you may face in your practice? And with that, I'll kind of turn it back to you, or I'll hand it over to Jason, perhaps, for your thoughts.
That's great. Thank you so much, Dr. Patel. That's all excellent. I'll remind people, answer the polls as they come up. Any questions or comments, please put them into the chat, and we'll hand the microphone over to Dr. Roostaeian. Oh, I have you muted there.
Unmute. There it goes.
Perfect.
How's that? I think the poll came up at the same time, so like my whole screen went away. There it goes. Yeah, that was an amazing overview by Dr. Patel. Honestly, I think he hit all the main salient points. I think for this article purpose, I understood why they wanted a consistent landmark, because otherwise, you have too many variables. I think they used the medial canthus because it was something stable that you can then measure against, versus if everyone's hump starts at a different location. But I absolutely agree that when we're thinking of the radix osteotomy site, it's going to be where the bump starts. You're not going to go up at the medial canthus at it. And I think that's an important thing to remember. I do really like the safety aspect of this, and the aspect that, what are we most worried about? The cribriform plate, right? And it's a far distance away from generally where we're going to be working in terms of the humps. But you got to remember, a lot of the attachments, like the ethmoid plate, is directly attached to that. So it becomes really important. Probably more important than distance to me is how you handle the ethmoid plate, and going into techniques not causing a twisting motion and more nibbling away at the bone and minimizing, like Dr. Patel said, how much bone you're resecting from that region. And the way to think of preservation is that an important concept is blocking points. And so everything has a potential area preventing you from the motion that you want to have. And so the ethmoid plate's one of them, but it's also one that tends to, it's a relatively, it's one you don't want to overdo too. So in general, I think, you start out just like with a superior septal strip, you take out small strips of cartilage, reassess, you take out a little bit more. You can always take out more. You overdo it, you can't put it back, or it's very difficult to put it back. And I think that's a very important concept in rhinoplasty in general, but probably even more so when it comes to preservation rhinoplasty.
That's great. Thank you so much. So why are we seeing this growth then? I'll put this out to either Dr. Roostaeian or Dr. Patel. Why are we seeing this growth of dorsal preservation rhinoplasty? And I mean, certainly we're hearing more about it now. We're seeing more publications come out, and it's certainly gaining a lot of traction. I don't know. We've got some poll questions coming up to see what our participants tonight, whether they're doing it or not. But how do you explain that growth? And for those of the attendees tonight who aren't doing it, why might they want to consider incorporating it into their practice?
I think first of all, I think it's gained a lot of, it's new and exciting, number one, but there's a lot of validity to, not, if something's working in general, in plastic surgery, if something is already aesthetically close to our endpoint we want to achieve, then why are we taking it all apart and putting it back together? Because it's really hard to duplicate natural anatomy, and we all know that. And so it makes a lot of sense. Now, there's times where, and I'm trying to study this now too, where, between different methods of preservation, whether it always makes sense if you have a tiny little bony cap versus doing all the osteotomies that you need to for a like a letdown or push down procedure. You know, I think that's where it gets a little tricky, where there's definitely a lot of gray areas here. And I think doing it routinely may not make the most sense, because there's just plenty of patients that, like, I don't think we'll be able to tell the difference whether you just scratched down a little bit of the bone and or did an Ishida where you preserve the bony cap. And that may be this more simpler way, because you got to remember, I always think of it in the sense of what's going to get me to my endpoint the easiest possible way with the least amount of dissection and therefore the least amount of recovery. And so if I can, you know, minimize wide dissection and, you know, focus all my energy on the top and do surface techniques here without, you know, disrupting a lot of the anatomy. And I think a lot of that has to do with primarily the cartilage preservation and a little less for the bony for me. But somebody with like a really overprojected straight bony hump that you'd have to carry really far up, at some point you're going to run out of that runway that you have where the cartilage is robust. It's about 8 millimeters roughly for most people, where the cartilage kind of is robust and the bony cap covers it, and then it kind of peters out or it ends. And in those cases, you know, if you're going to resect more than that, it gets really hard to reconstruct that upper bony part. And that to me is a better indication for doing the, you know, bigger bony procedure, which is the let down or push down.
Yeah, I agree with those thoughts. You know, to go back to your question regarding why has this sort of become more interesting to people, I do think it is new and exciting. I do also think that, you know, Dr. Daniels had published this commentary, I think back in 2018, and that was truly in literature was this sort of spark that a lot of surgeons sort of use as a point of interest and dive into this. But you know, the reality is that in the US, perhaps preservation rhinoplasty has not been popular. But if you look around the world, these preservation techniques have been present and alive. And you know, I've learned from some folks in Mexico, obviously. There's folks in Europe and France in particular, Dr. Saban, who I'd mentioned. These guys have been doing it for quite a long time, and as their publications have been become more prominent, have been spread, I think, yeah, that's the article right there. I think that has really ignited interest in it. And then the second thing is like we discussed, maintaining the architecture, the natural architecture of the nose is very hard to duplicate. And so I think trying to minimize pulling everything apart and then just having to put everything back together, that is fundamentally what preservation rhinoplasty is. And so I think that's really what has ignited this interest.
And so is this something, Dr. Patel, I know Dr. Roostaeian just mentioned some of his criteria. Is this something that you will think about primarily and see if a patient's not a candidate for a dorsal preservation procedure, or do you go in with kind of a blank slate and try and determine, are there certain factors that will sway you towards an open approach where you're doing more of a takedown versus a dorsal preservation approach?
Yeah, I think for me, you know, I think it's all dependent on your patient population. Where I am at this large academic center, I have so many patients who go in and their septum is touching their ear. You know, I mean, their septal pathology is so bad that it sort of eliminates any modification or any preservation technique, because there's so much extensive septal work that I'm going to have to do. So that's one key fundamental element of all this. If you're going to really be taking apart the septum or doing extracorporeal septoplasties, et cetera, dorsal preservation just is not a thing. It's also interesting, you know, we sent out this survey. We did this survey study, an international one, about 2 years ago. And we asked people from around the country, well-known rhinoplasty surgeons across all different societies. And we said, well, what percentage of you are doing preservation rhinoplasties? And one thing that I think came up that was interesting is that it fundamentally comes down to your patient population. For example, there are certain patients or certain populations where just a big kyphotic hump is far more common. And the expectation of these patients is more so that they want sort of that less of that natural appearance. They want more of that scooped appearance. The reality of it is that dorsal preservation it's far less likely to get you to that truly scooped appearance from a very, very kyphotic hump. And so, ultimately, patient population is a driving factor. And so for me, I find that I certainly do less preservation rhinoplasty than I do structural stuff, in part because of that patient population that I have here. There's other things, especially when you're starting. For me, I would go in and find patients who have less of this huge kyphotic hump and more of this. And there's a description of two different types of nasal bone anatomy or shapes. The first of which is this V shape versus an S shape. The S shape being between your radix and your rhinion, there is another apex before you get to your rhinion. That sort of kyphosis there. Those patients have a higher likelihood of having a hump recurrence or hump persistence, really, with preservation techniques. So when I started doing this, I would go in and I'd find the patients who I thought, hey, you don't really have a super crazy looking hump. The amount of descent that I need is not insane. You don't have this really thick skin. You actually have thin skin, so preservation would be beneficial so that I'm not creating these irregularities in the dorsum. And then ultimately, it was, I find myself doing it more so in patients like males because they're less likely to want the expectation. I think Dr. Saban actually talks about it. They're less likely to want that sort of slightly lower dorsal height than a female patient. So they're going to be more forgiving if you have not a perfect drop. And so when I started, those are elements that I was looking at using.
That's fantastic. One question I'll put out to both of you before we get a little bit of poll feedback from Dr. Zamani. In his commentary, Dr. Most mentions this kind of concept of the high dorsal septal asymmetry, and that's an ideal patient for the dorsal preservation rhinoplasty because we can get a little bit less predictability or potentially more variability if you're doing osteotomies and trying to close an open roof. What are your thoughts about that? How do our attendees assess that in their patients and figure out if that's going to be a factor that may sway you towards a dorsal preservation technique?
Yeah, I think there's two aspects to consider. Is one, you can use dorsal preservation, especially if you're going to do like more of a mid strip. Separate, you can straighten out your mid vault by shifting it over and securing it on the opposite side of the septum. So that's one aspect. Another thing to be mindful of is, and where the caudal is really excelled, is if somebody has significant ethmoid deviation, that, if you think about it, if the ethmoid is way off and that's where your L strut's got to attach to, it is preventing you from ever getting your septum perfectly straight. So the caudal, where you separate it from that deviated ethmoid, can be really powerful because it's basically a flap that you can, make sure, secures into the midline and separates the, crooked ethmoid from that septal flap. Then on the bony side, with axis deviations, assuming that the roof of the nose is straight, but it may be tilted one way or the other, you can do asymmetric, you can do a letdown on one side. And so basically, if you think about it, often with a crooked nose, there's a longer bone and a shorter bone. So imagine the longer bone, you can take away more from the base there and do a more larger letdown from the longer side, which means resecting more from that side, and maybe just a push down on the opposite side, or do a smaller letdown, and that can allow the house to tilt back over. It's not going to work if you have really wide nasal bones or really high, if the top isn't worth preserving, then this doesn't, make a lot of sense. But if it is, and you can just shift the whole thing, it makes the operation way simpler because, it's really hard to do all these, intermediate and multiple level osteotomies. And it's really easy to lose control of multiple small pieces of bone rather than one large unit of bone, which essentially what you're doing when you're doing a push down or let down. You're impacting the whole nasal bone as one unit down, sliding it, or moving it, angling it, rather than having multiple small pieces of bone.
That's awesome. That's great. Dr. Patel, do you have any other additional comments?
No, I think with Dr. Mo's commentary, I think that's one thing that he alluded to is, hey, maybe that is an area where the CT scan would be valuable to assess that sort of high septal deviation. Perhaps you can figure out that that's an issue. Maybe that will drive you towards the preservation stuff. Another thing, regarding the asymmetric letdown and the asymmetric pushdowns, or really it's an asymmetric letdown. One thing that even for my structural rhinoplasty patients, something that I've started to do just as I was getting into preservation rhinoplasty, I actually that became the way that I started correcting dorsal deviations. I would actually make a lateral osteotomy, a transverse root osteotomy across the other side, connected with my lateral osteotomy on the other side, and then I would do an intermediate osteotomy. And even though I wouldn't remove a chunk of bone, there's going to be some telescoping on the side that you made that intermediate osteotomy side. And so then that whole complex would shift. And even though you haven't really released it from your septum, I was finding that, gosh, I'm able to really move that whole complex. And again, it's the same thing that was just mentioned where, gosh, now I'm not moving like the left nasal bone and the right nasal bone, and then I've got this middle segment that I'm trying to force over. Now I've got this whole big complex that I can shift over. And so even in structural rhinoplasty, I found that technique to be valuable in changing the position of the dorsum, and certainly it's the premise in dorsal preservation.
Fantastic. Thank you so much. Dr. Zamani, I've seen some polls pop up. I've seen some flashes from the chat box. And do you want to give us a rundown and let us know where things are at?
Absolutely. But before I get into that, we do have Dr. Nahai present amongst our midst. And I'm going to invite him to join in on the conversation and commentary. And I know that he has some questions for our panelists, actually. So I'll hand the floor over to Dr. Nahai.
Thank you and good evening. My thanks to the speakers. You've done a great job covering the article. The question I had, and Dr. Patel partially responded to it in his discussion, is how often are you doing the standard open, as you refer to it, structural rhinoplasty, as opposed to the preservation technique? A question for you and for Jason. I've yet to come across a series where this technique was used in any secondary procedures, but the question I would have, an isolated dorsal quote touch-up, which would be your preferred approach? Would you approach it the standard way, or would you try this technique?
So it's a great question. I haven't ran into that where it was an isolated dorsal hump for revision, because typically with revisions, I've noticed people nail the profile and get rid of humps pretty, are pretty facile with that. Usually where people go wrong is asymmetries, bad tips. But absolutely, I mean, if there's a, I think I'm going to say it's probably doesn't exist. It's going to be like the unicorn. But if somebody had like a perfect dorsum and they like somehow didn't, somehow the last surgeon just decided not to do it, and now that's the only thing the patient needed, sure. Because
I guess what I'm asking you is if someone has had a structural procedure and they need a revision, is it out of the question to use the preservation technique, or would it have a role?
It wouldn't be out of the question. It would really depend on how much L strut was left. For instance, if I was going to do a superior septal strip, would be way more likely, because probably that's the only place you could take away from the septum and still be safe. But obviously you want to stick to your structural principles of leaving at least 1 centimeter by 1 centimeter L strut. So that's going to be in general pretty rare, but possible. But if somebody did preserve a natural upper lateral cartilage and dorsum, then I would like, and I can preserve it, I would like to, but that's in general pretty rare. So generally, I'm going to say for revisions, it'd be, very unlikely to use the preservation principles unless they had maybe a preservation procedure the first time done, and then that will change things. But so far, I haven't really ran into that. Does that make sense?
I agree completely with that. You know, there's this idea too. When I first started learning about preservation rhinoplasty, I was like, oh, it's an entirely closed procedure. You don't open up anything. All the cuts you make are with endoscopes in the septum. And there have been a couple of folks now that have published on this concept of structural preservation rhinoplasty, which is sort of this fusion of these two concepts. And in fact, I do all of my cases open. And so even when I'm doing a preservation case, I do it open. So could you convert a revision case to preservation? Rare in part because of what was mentioned. I find it unlikely that a surgeon will have left a good amount of septum that would then be amenable to any form of further resection and drop of your dorsal height with a preservation technique. But because I do my cases all open, and certainly my revision cases open, you theoretically have the ability to make that game time decision once you have everything exposed.
Just one final question before I hand it over to Maryam on this technique. Would each of you tell us your learning curve? Did it take you 5 rhinoplasties, 15, 50?
So I think the best way to start with dorsal preservation is with the surface techniques of and cartilage preservation. I think that's honestly where it has the most utility anyways. I think the superior septal strip and or just trimming the any excess upper lateral cartilage horns, for instance, is the best place to start, and where I started, and what I recommend for anyone just getting started in preservation rhinoplasty. And honestly, at the end of the day, has the most utility because I still like a structural tip in the vast majority of cases, and I think it turns out a little bit better overall for the aesthetic I'm looking for. But so I think, but it's not just dorsal preservation too. I think the other concepts of subperichondral dissection, especially in somebody with really thin skin and strong cartilages. Doing alar preservation is critical. There's other concepts that are important to remember in the preservation overall, and closing down dead space and reconstituting the scroll and or Patengi ligament. These are all things that I think are relatively straightforward to incorporate, and probably the best place to start, and minimizes the learning curve.
Yeah, and I totally agree with all that. I'm not even sure there's a specific number because I feel like I'm still learning preservation rhinoplasty with every case that I do. I think there are certain elements that will help the learning curve. I was lucky enough to attend some of these meetings and learn from people who have been doing this a long time. And then secondly, I find myself, and I don't know how many people have access to this sort of resource, but I find myself going to the cadaver lab, honestly, and just messing around with just anatomy and seeing how things would work before I really started doing this in patients. And I think that particular element really helped me because I think it's more nerve-wracking to just go into a patient and just do it for the first time. And I'll tell you, most of you will have success with that, but I think your comfort level will be far greater if you've either attended a lecture series, a hands-on session with some of the experts, and maybe even tried some of this stuff yourself on a cadaver.
That's always a good idea. And watching somebody who does it is always ideal too. And I think a very important aspect, going to go see other surgeons who perform it before diving in is always helpful, and the right way to do it.
Yeah.
I think that's a fantastic segue to us speaking about our polls and the respondents that attended tonight. And the majority, 67%, have never performed a dorsal preservation. As we've talked about, this is kind of a new resurgence of the methodology, and it is quite a different way of thinking about our approach to rhinoplasty and performing it. So definitely a lot of interest here, even among our attendees today. And following our discussion, 77% have indicated that they would like to learn more about dorsal preservation and integrate it into their practice, which is always lovely to hear about. Now, kind of more specific to the aims of this article, talking about whether or not we're using CT imaging prior to rhinoplasty procedures, 47% have never used it. And I think that probably has to do a lot with respect to access, resources, and the such, whereas 13% always use. And again, I think that's reflective of maybe the region where you're practicing and the resources and health coverage, because, I imagine in the US, the ability to get any kind of insurance coverage for CT imaging prior to rhinoplasty is quite difficult. Is that correct?
So yeah, I would say, I mean, if there's not a nasal airway obstructive component to it, and they're not using their insurance at all, it's going to be pretty much prohibitive to do that. But with that said, I mean, I think there are plenty of opportunities of patients who do come in with breathing issues and are wanting to use their insurance, especially if you practice out of an academic center like I do at UCLA, then it makes it a lot easier. And definitely, I don't force it on my patients, but often they have already, through their primary and or if they saw ENT first, had a CT scan already anyways.
And otherwise, do either of you use an endoscope when you're doing a dorsal preservation or any kind of adjunct? So is that something else that, if a surgeon is thinking about undertaking this measure, and that should be something they're investing in terms of better understanding that deeper, more cephalic anatomy, especially at the osteocartilaginous junction when you're making these kind of decisions? Is that a worthwhile tool for them?
I use it with every case because I think, I always want to treat the airway from front to back too, just for that reason, and before ever even worrying about dorsal preservation. Mm-hmm. It's super helpful, and I think it will, it's definitely nice to have that, and you're able to do a better job because you just don't have the visualization without it to the same level. With that said, as far as dorsal preservation goes, you're definitely able to do it without it. You can use a needle and, poke to find your E points or K points in this article. And you could find those junctions and work around it for sure. There's plenty of surgeons that do that. So it's not mandatory by any means, but is it a useful tool? Absolutely.
Yeah, I agree with that. I generally use an endoscope for the airway component of surgery alone. And then there've been a handful of times I've used it. Probably 50% of the time I've used it for any sort of septal cuts that I've used, but 50% of the time I haven't. And so I think it's a great adjunct, but not absolutely necessary.
That's lovely here. If there's any more questions from our audience at this point, I invite you to submit it into our chat box. And we will surely address them, because I think that we're coming up to the closing time. Is that right, Dr. Austin?
That's great. That is right. I'm trying to respect everybody's evening. I have one more question for each of our presenters. Dr. Patel, you mentioned briefly the piezoelectric technology and SAW. If that's not something our attendees are familiar with or have exposure with, can you just give us a little bit of background about what that is and how you like to use it?
Yeah, so it's an ultrasonic saw that now there's a couple of different manufacturers that make it, but the idea here is that it will use this ultrasonic power that will cut your bone or rasp your bone. Even there's a variety of different tips. Something that's extremely helpful is those of you who ever want to make a small little hole. It's even got a little drill bit on it that will allow you to make a hole. But rasping, cutting, curved cuts, straight cuts, and then this drill component without damaging soft tissue. And so I think it's become incredible in my practice, not for preservation, but even for structural stuff. You can imagine after teaching, gosh, after you've done these osteotomies, you can't get a rasp back up there to start pushing on stuff. Well, you can with the piezo, and so you can fine tune things. And I think for that reason, it's become extremely valuable in my practice.
That's great. And Dr. Roostaeian, with the growth of social media changes, we're seeing more people are talking about this. In LA, is this something that that patients are asking for or talking about, or is it not quite gotten to that level yet?
Not to a significant degree, I would say. It hasn't fully penetrated, but there's definitely on occasion. I think some people do come in asking for the piezo, and some people I could tell have like seen posts about it and are like asking about it. But you know, I think part of it is because probably like local surgeons, there's not that many that do it yet. So like the vast majority of people don't talk about it, you know. So I think with time it's going to probably, you know, become more and more talked about, honestly.
And are patients asking about dorsal preservation specifically when they come in now, or is that?
Yeah, I would say that's the most common, would be dorsal preservation for sure.
Okay.
Because I mean, we are going to create what the patients talk about, if you think about it. So it's like circular. So as we get more and more interested in this and talk about it more, then the patients are going to be more and more wondering about it. The one interesting about piezo and the difficult thing, Dr. Patel, like it's listed as a single use. And if you work in an academic center, that's one thing I'm struggling with, is like, you know, financially for the academic center, like, how are you making that work? Because like, it's a point of contention right now.
Yeah, you're not alone. Actually, Scott Owen, who is a facial plastic surgeon at the University of Iowa, I was talking to him 2 days ago, and he was at the Dallas Rhinoplasty course, and he said the same thing. Hey, this is impossible to get at an academic institution. You know, our dental folks, our oral maxillary facial surgeons were the ones that started using it. And then one day we all decided that we were just going to throw this massive fit and be like, we all need it. We absolutely need it. And so all of a sudden it was wild. They were like, oh my goodness, our surgeons are going to stop operating if we don't get them this piezo. Because we had one that we were all sharing between 5 or 6 of us, you know. And so they realized, like, man, these surgeons are going to cancel their cases. And so all of a sudden one day, and this is an anomaly, they ordered 2 more. So now we have 3. And it's just sort of become like, they just think that, hey, if you're going to use it, you know.
But you blow through multiple tips on each case, and it's like between the tips and the tubing, you're talking like $2,000 per case, right there.
Yep.
Yeah.
You know, and that the cost, you know, will get transferred off to your patient. You know, so I think that's a thing that for cosmetic only rhinoplasty certainly has to be considered. The other thing, and I know this is not necessarily the way that any company would want to hear this, but there have been a lot of folks in private practice that I know who have the piezo that will reuse.
Oh, everyone.
Yeah.
Everyone.
So
not a single person that owns it only uses it single use. Right. And that's why, like, honestly, they're just kind of hurting exposure to trainees and hurting themselves by not opening it up to making it multiple use, because, you know, you have everyone else out there doing it, but then like the places where more people can get exposed to it in academic centers, they're like, it's more restrictive and harder to get in there because they have to do everything to the you know, standards of what's listed. And, you know, really, like, I don't think they realize it, but they're just hindering the progression of piezo technology among all surgeons out there. And I don't know that that's necessarily the smartest business move in the end. They don't, you know, I know it started out that way. It makes a hell of a lot of sense, but I think it's starting to bite in the ass because everyone's like, oh, well, this is metal. I'm not going to reuse it. You know, I'm going to reuse the tip.
Yeah, we have not been able to get past that at the academic institution. I'll tell you that. So
you won't. Yeah.
But that's great. Listen, I'm trying to be respectful of everybody's time tonight. We have 10 minutes to the hour. So I think with that, we'll cut off tonight's Journal Club. That was some excellent discussion. And thank you so much, Dr. Patel. Thank you so much, Dr. Roostaeian, for coming out tonight and sharing your expertise. Dr. Larson, excellent presentation. And to Phaedra, Dr. Nahai, and the entire ASJ team for making these sessions possible. Thank you all for giving us an hour tonight. It means a lot to us. So make sure you head over to ASJ, read some of the links that you have in the commentary box. Get out if you're interested in learning about dorsal preservation rhinoplasty and implement it into your practice. Certainly, we've got excellent resources out there, and there's going to be vastly more information to come and more content from ASJ. So everyone, take care. Have a good night. We'll see you next month, second Tuesday of the month, for the Young Aesthetic Plastic Surgeons Journal Club, hosted by Dr. Mark Albert and the rest of the team. Take care, stay safe, and we'll chat soon.